for inviting me to give this talk. It's a real privilege to be over here, and thank you for honoring me with this particular subject. I'll be talking about one of my pet areas, diabetes in the young, and I'll start with an introduction and disclaimer by saying that when we think about young people in India with diabetes, certainly the most common thing which is now above the age of 25 is in fact type 2 diabetes. Having said that, we have a large proportion of people who are lean, who have BMIs less than 20, and this is an area which we really need to understand better, and that's been my passion over the last few years. Initially, we were stimulated by work by my predecessor, the first biostatistician in India, Dr. Nihal, started the Vellore cohort in 1970, which we still follow up every 5 to 10 years by doing epidemiological work in collaboration with biostatisticians. What we showed from this data initially was that post-absorptive lowering of glucose, this peculiar phenomena of a low glucose after a meal, may be associated with the lean body habitus, but better insulin sensitivity. But why do we have this category of people who are lean, who have hyperglycemia at the same time and progress to diabetes? We have done epidemiological work, and in fact this is true incidence data based on the baseline birth rates and the progression in life over a period of 44 years. And this is the 44th year when we did our screening in Vellore, and we divided them into a rural population and an urban population. And you can see over here that by the year 2014, the prevalence of diabetes is enormous, that in urban Vellore as well as rural Vellore, and mind you, this is truly rural, population density of less than 600 per square kilometer in a market town less than 50,000. So this is truly rural, but practices have changed even in rural areas in Tamil Nadu, and so that's been the issue right across Kerala for many years, and therefore there's an equalization of the prevalence of diabetes over here. We started our inroads into genetics with collaborative studies, and sometimes I call these post-office studies because we had this large cohort, we had the blood samples, but we did not do the genetic test by ourselves. We collaborated with the Oxford University and the University at Karolinska and did this work. And we showed that there were certain single nucleotide polymorphisms causing hyperglycemia, affecting beta cell function, different in their behavior compared to the European populations where you had no birth weight association. The common FTO single nucleotide polymorphism, very common across many populations, is associated with diabetes as well as an increased base circumference. And the MC4R, another single nucleotide, can be associated with a big frame. You see these big people who have increased amount of weight as well, who appear to be morbidly obese but are relatively healthy. We started doing school studies way back in 2007, and this is the prevalence of impaired fasting glycemia in Vellore in a school, showing that boys between the age of 14 to 17 had an IFG of 20%, glucose more than 100 milligrams, and 20% of school boys in the year 2010. A few years later, we studied the parents and the children, and we found that there was a strong relationship with the maternal base circumference to the child's base circumference. We thought this was learned behavior, and if both parents had the problem, that this was increased by almost 6 times. The same population, we looked at the FTO mutation and single nucleotide polymorphism, and we found there was an association between this and the base circumference. So it's, yes, it is largely behavioral change which has induced learned behavior, but there is a genetic component to a smaller extent as well. With the World Diabetes Foundation, we collaborated and did this study, this is a training program across the country over a period from 2004 to 2009. We covered 100 rural hospitals across India, and we trained doctors, nurses, and food care technicians. Now we generated epidemiological data from some of these hospitals in rural Tripura, and this was the first true epidemiological study in rural Tripura, the rural northeast. In the year 2006-2007, prevalence of diabetes was around 9%, and overweight prevalence was around 31%. The median age was 44, plus or minus 14 years, indicating there was a good number of patients who had diabetes below the age of 35. Similarly, in Arunachal Pradesh, and even more backward area, we had 5% prevalence of diabetes in relatively lean individuals with BMIs less than 21 in a good number, And again, the median age, good number were in fact less than 32 years of age. More recently, we have been working with the ICMR and have done technological work in Meghalaya, and my colleague Felix has been working intensively on this. We have generated data across other tribal areas as well and integrated, and we found similar large proportions of diabetes. The population in Meghalaya compared to many other parts of India is relatively more healthy. People are more lean, more sturdy, and of course are used to long walks as well. But even they too have a prevalence of diabetes which approaches 6 to 8% in Shillong and surrounding areas. Back home in Vellore, my colleague Nitin Kapoor worked with the community health department, and we generated data in terms of lean diabetes. Now this is truly lean, BMI is less than 18.5%. It is uncommon in Vellore. The so-called percentage of malnutrition right now is actually quite low. So when you talk about adults, 0.6% in rural areas and 0.3% in the urban areas had diabetes with very low BMIs. But with a large population, that is still significant. So when you see a lean person with diabetes, besides type 1 diabetes, or besides the autoimmune slowly evolving intermediate diabetes, there are other conditions you should consider. Very often, young type 1s are not screened for. So if you have someone who has diabetes which needs insulin within 2 years, you should think of an autoimmune cause as one possibility. And you should measure the C-peptides, GAD antibodies, and you should do an imaging of the abdomen. You all know that fibrocalcific pancreatic diabetes is thought to be very common in Kerala some years back, but its prevalence has apparently dropped over here. But you still do need to look for it. Beta cell dysfunction disorders, some of them can be lean. Certain forms of monogenic beta cell dysfunction, condition called lipodystrophy. Wolfram's, I'll cover these briefly. HIV lipodystrophy, and last, very controversial protein deficient or malnutrition related diabetes is something which we should be talking about. So when we see patients with young diabetes, this is what we do. We should take a very good history. I always ask patients about their birth weight, and if they don't know their birth weight, I ask them to call their mothers and ask them, what was my birth weight? This is important. Very low birth weight, BMI is less than 2.2 kilograms, predispose you to type 2 diabetes later on. Birth weight more than 4 kilograms can predispose you for diabetes later on, because that is essentially indicating that probably your mother had GDM and didn't know about it. Check C-peptides, check GAD antibodies once they are lean, because you could be dealing with slowly evolving autoimmune diabetes, and do a DEXA to check the body composition, the percentage body fat. People with young type 2 have percentage body fats. Males have percentage body fats more than 30-35%. Females more than 40-45%. But if you're any of the other categories which I told you about, the percentage of body fat is usually very low, less than 25, and in malnutrition it's even lower than that. And then, to look at the pancreas, an ultrasound is really not good enough. You miss calcification, you miss a shrunken pancreas for almost 50%. So if they can afford, it's always better to do a CT scan. Once the C-peptides are low and the antibody is negative, do a CT scan, and then genetic testing which comes into play. Bit about fibrocalcific pancreatic diabetes. Classical history, abdominal pain, no history of alcohol ingestion, manage initially on oral antidiabetic agents. That can happen. Shrunken pancreas, calcification in the ducts, and markedly atrophic pancreas. Low stool elastase, which is a marker of malabsorption. The normal is more than 200. So, fibrocalcific pancreatic diabetes is common in males, 70%. They do not have peripheral signs of insulin resistance, they have low C-peptides, and the abdomen CT scan is always positive. And we have indices to measure pancreas size, duct dilatation, and look for calcification. If they live more than 50 years, 40% of them will get pancreatic cancer. So surveillance on an annual basis is required. This study done in Lucknow, in North India, showed that 15% of patients, and this is of course a few years back, we did the genetic testing in this population, 15% of them had fibrocalcific pancreatic diabetes. So it is still very much there in various parts of the country. We also discovered that a good number of these patients have osteoporosis. And it is not associated with vitamin deficiency. It is associated with the fat malabsorption, a substrate problem which is there. We also looked at the energy expenditure using indirect calorimetry. We found it was paradoxically very high. And it's a very important thing. There are 3 reasons why these people are lean. Number 1, the sugars are not controlled. Number 2, they have fat malabsorption. You need to give enzyme supplements. And number 3, they have paradoxical energy expenditure. I'll tell you the reason for that very shortly. So they need big calorie diets ranging from 2,500 calories or maybe sometimes even more, which is very often neglected in patients who have diabetes, and particularly in this group. Other things which we found, 60% have autonomic dysfunction, which can exacerbate the diarrhea. They have multiple nutritional effects. We need to be careful with stool elastase. It's not as good as measuring stool fat. No one does it anymore, which is difficult to do. But stool elastase can give false positives in even patients who have any kind of diabetes for 5 to 10 years because of subtle autonomic dysfunction. So we looked at hypoglycemia in these patients, and we also looked at autonomic dysfunction doing continuous glucose monitoring and autonomic function testing. And what we found was that they had, those who had low glucagon levels had hypoglycemia, understandable. But we had a subset who had high glucagon levels. And why should that happen in a shrunken pancreas? This is inexplicable. Why does it happen? Glucagon levels are high, it's a shrunken pancreas. Alpha cells seem to be knocked out. So this is the thing which we found over here. And this high glucagon can drive energy expenditure. It works on the mitochondria and physiologically it drives it. And that's the reason for the high energy expenditure. So the next step is we try to figure out why do they have high glucagon levels. So we measure the incretins in these patients. C-peptides were low, yes, marker of insulin deficiency. The K-cell function, GIP, was elevated, was normal. But in patients who had FCPD, the glucagon levels were elevated, the GLP-1 was elevated, and the oxytocin is elevated. The last two are produced only by the L cells in the intestine. You all know about semaglutide and liraglutide, and so that is what can be increased by using by giving a medication, or rather using an analog for treating diabetes. But these patients had baseline high GLP-1 and oxytocin. And this brings us to the hypothesis that probably what we are dealing with is the L cells start producing glucagon once the pancreas is shrunken. The same genome which is there in the pancreas, which is responsible for glucagon, gets reactivated, and besides producing GLP-1 also starts producing glucagon from the L cells. And experiments in pancreatic mice dogs and in patients after pancreatic surgery have shown that the same phenomena can happen. So glucagon is coming from an extra pancreatic source. So this is the things which we need to know. Mean diabetes is most frequently missed when we think about FCPD. We need to rule it out. Treat osteoporosis. Look for autonomic dysfunction in these patients. Hypoglycemia is common, but it's only mainly associated with those who have low glucagon levels. High glucagon levels are seen in a number of patients with FCPD. We need to treat with enzyme supplementation, and we need to give a high calorie diet to these patients. The next one is the monogenic beta cell dysfunction. You all heard about body or monogenic diabetes in the young. We were the first in the country to start using next generation sequencing. Previously what we used was Sanger sequencing, where we can line up multiple genes together and do at the same time. This was published in 2014. This platform is now used for many other disorders, including breast cancer, congenital adrenal hyperplasia, and about 400 other genes which we are using in our lab to diagnose these conditions. So 19% of our patients who had hereditary classical young diabetes had identifiable mutations for MODY. Now, we also looked at young people who were pregnant, who had BMIs of less than 23, and who were aged less than 25. Why should they develop pre-gestational diabetes in the first 12 weeks of pregnancy? Obviously, they had diabetes before getting pregnant. And we found that 18% of patients who were insulin requiring had monogenic mutation. And this is important because some of these monogenic mutations respond to sulfonylureas. The MODY 1, 3, 12 and 13 are all sulfonylurea sensitive. So normally for gestational diabetes, after they have persistent diabetes, you continue with metformin. But over here, this subgroup you might want to consider glibenclamide as a therapeutic agent. So low dose sulfonylureas for MODY 1, MODY 3, standard dose for MODY 1, and then this condition called ACNJ mutations, MODY 13, you give mega doses. Some of them come with neonatal diabetes and diabetes in the young. Huge doses of glibenclamide, 40-50 milligrams. But fortunately, glibenclamide is a very cheap medication. 16-year-old girl, diabetes, during routine testing on thrice-daily insulin, had largely CRF at her presentation, and subsequently she did not menstruate. We ruled out Turner syndrome, which was something to think about, but she had normal breast development as well. And then we looked for obstructive causes, so we found a biconate uterus and absent cervix and vagina. And in addition to that, the MRI showed a shrunken pancreas. So this is basically a patient who has OD5 and young onset diabetes, renal cystic disease. The males, you can have infertility due to an absent vas deferens and pancreatitis. So they can have phenotypic pleiotrophy, that they can present with different presentations of the OD5. Someone can come with infertility, somebody can come with diabetes, somebody else with malabsorption, different presentation. 60-year-old boy with ketoacidosis, very lean, antibodies negative, very low C-peptide. So this is the kind of malabsorption. We did an imaging, showed a slightly atrophic pancreas, not very prominently atrophic, but then the next thing is, these are the kinds of patients where we do genetic testing. And we found insulinopenic variant of OD5. So OD5 is phenotypically pleiotropic. Some can come with mild diabetes, some with ketoacidosis, and some with what looks like FCP. 29-year-old lady, first pregnancy 5 years ago, history of oily stools, intermittent abdominal pain, ultrasound was reported as chronic calcification, calcium pancreas, but the stool elasticity is normal. Here the CT, there's no calcification. But what you see, that white structure is actually a splenic vein, which means that the pancreas is grossly atrophic and there's a lot of fat replacement over there. And this is another kind of monogenic diabetes called carboxylipase, ethyl lipase mutation, where you can have a shrunken pancreas with diabetes with a lot of fat replacement. 43-year-old nurse with lean diabetes for 15 years came with history of acute pancreatitis. You can see the grossly swollen pancreas over there. CT scan during one of the episodes. Then I treated her for about 14 years. After that, I thought this is run-of-the-mill chronic calcific pancreatitis, and there's shrunken pancreas, calcification, and the prominent splenic vein, and she was doing okay. Then her daughter developed extreme fatigue and couldn't get up from the squat, recurrent episodes of migraine, and she had classical feature and lactic acidosis. This is MELAS syndrome, mitochondrial enteropathy, lactic acidosis. Now, incidentally, my wife is a pediatric neurologist, and she called me and she said, "You have not been managing the adult as well as you should have. You should have told me that this patient had pancreatitis." And I said, I didn't want to have an argument with my wife, and then I said, let's do a genetic testing, and we found this was a mitochondrial mutation over here. So this is heteroplasmy. If the heteroplasmy is more severe, as in the daughter, they come with early presentations, more severe presentations with MELAS, whereas the mothers coming with the milder heteroplasmy coming later on in life with diabetes and pancreatitis. So mitochondrial dysfunction causing pancreatic atrophy. 20-year-old male, recurrent respiratory tract infection, steatoria, stool elastase, 18 micrograms. Anyone wants to make the diagnosis? I think that sweat chloride is a way over there. Diagnosis? Okay, this is supposed to be unknown in India previously and very rare, but this is cystic fibrosis. Common in the West. Now we should not miss this. And sucking respiratory infections, you might not think too much about it. The patient has a double mutation, SPINK1, which is the common cause for hypercalcific pancreatitis, plus cystic fibrosis at the same time. So we now have a pancreatic panel, and if you have a pancreas which is shrunken, calcific, there's malabsorption, you should do this pancreatic panel, and we are doing this routinely in our patients who have, even our gastroenterology patients are being referred, and even children who come with acute pancreatitis condition. So we have done a study more recently and looked at this, it's gone to press now, wherein we have looked at classic hypercalcific pancreatitis and patients who have dorsal agenesis, diabetes, and you find an incidentally small tail of pancreas in these patients. And we have found a number of mutations. Now I could go into one lecture on this because each of them has a different clinical presentation, different mutations. Some in young people, some in older people, some with other syndromes at the same time in addition. And we have drawn up an algorithm for investigating these patients Lipodystrophy, another cause for lean diabetes is people who are young, 38-year-old lady, diabetes at 19 years, hyperosmolar symptoms, diagnosed as type 1, like a lot of other people. But she had markedly reduced body fat. She used to stop her insulin for 5 days, she used to go up to 600, but she didn't develop ketoacidosis. So this is called lipoatrophy, and in addition to that she has prominent veins, it's called phlebomegaly, and she had proteinuria and a very high triglyceride at the same time. So the insulin levels were sky high in her, and the C-peptide was also high, very elevated in these patients. We did a DEXA scan, we found very low fat, but the head had a slightly increased fat. It's a pseudo-Cushingoid appearance of a very lean person. This is called lipodystrophy. It's an autosomal recessive condition, therefore much less common than MODY, monogenic fetal cell dysfunction. And you can get more severe forms, very young people, severe atrophy, severe stunting, cirrhosis at a young age, less than 20-25 years of age, cirrhosis, and fatty liver is seen ubiquitously in them. So we have someone who's thin with a fatty liver, think of this particular condition. We have another genetic panel over here for lipodystrophy, which we do for our patients as well. So lipodystrophy has C-peptide levels which are elevated, fat is low, but they have a pseudo-Cushingoid in the partial lipodystrophy and the couple lipodystrophy. They are stunted, cirrhotic, fatty liver is ubiquitous, and 50% have what is called the laminin mutation, which causes partial. The good news is the partial lipodystrophy and 80% response when you add pioglitazone to the insulin. And if they are 200 units of insulin, suddenly the requirement comes down to 30 units per day. Here's another condition. 20-year-old man with classical symptoms of what like type 1 diabetes, frequent urine icturition, uncontrolled diabetes, diagnosed and clubbed as type 1 like every lean person. The thing over here, when you have high sugars which is uncontrolled, what happens to the sodium? The sodium will be low, you get pseudo-hyponatremia. But here we had high sodium, and that was the clue. High sodium means there's something else going on. We check urine specific gravity was low, urine osmolality was low, C-peptide was low. So diabetes mellitus with diabetes insipidus, and that is called Vellore syndrome. A genetic condition which is classically autosomal recessive, but these things can behave differently. You can get heterozygotes also who come with milder or the Wolfram's-like syndrome. This is the classical presentation. Sister of this boy came with a rapid progression, diabetes, loss of vision, deafness, and then subsequent seizures, other neurological symptoms, and passed on at the age of 26 years. And this is Wolfram syndrome. You can get Wolfram's-like syndrome, and therefore you should look for it in young diabetic patients. And later on, they can develop neurological progression, which can be picked up, and there's a treatment for it. That's the good news. This is a publication of Wolfram's-like syndrome in New England Journal of Medicine, showing you the spectrum that most of them, of course, require insulin. And the news here is that basically they start off with diabetes, the black dot, the y-axis is the age, then they develop optic atrophy, and then they may develop other problems like hearing loss. How do you prevent this? So there are studies now which show that there's promise using sodium valproate in these patients. So you genetically prove them, start them early in childhood. This is much more relevant for a pediatrician or an adolescent medicine person. Valproate can be used. There's another medication called idipinone, which is not on the slide, which works in hereditary Leber's atrophy. That may also work in this condition. And we have started these patients routinely on valproate and are following them up. Finally, the last condition, which is a controversial condition because it was taken off the WHO classification. Lean people from rural areas without type 1, without malabsorption, normal imaging of the abdomen, etc., with high glucose levels according to the initial definition, low body weight, very low BMI, coming from rural areas, impoverished backgrounds, and BMI is less than 18.5 without any other conditions, and requiring, according to them, high doses of insulin. It was not phenotyped or genotyped properly. But increasingly from across the world, there are reports of this condition still there. West Indies, Africa, several populations, Ethiopia, and the recent one where we analyzed along with the Ugandan group and also found that this condition exists. So we did a very long drawn out study. It was very difficult to do the study. because we don't find a lot of these patients in Tamil Nadu. So we did the entire workup, full genetic testing, 62 genes for monogenic diabetes. We did glycosylphosphate genetics. We measured the C-peptides were low, and we also did an MRI of the abdomen, the pancreas. We did DEXA scans to get the percentage body fat, and we did these very elaborate studies called hyperinsulinic euglycemic clamp studies to look at the insulin resistance. And of course, they were not insulin resistance. We also looked at energy expenditure, and we measured the hepatic glucose output, which is elevated in type 2 diabetes. It is not elevated in these patients. They also had insulin deficiency, but they did not require insulin in about 50%. And that's the good news over here. So 50% of them managed with oral antidiabetics. So this condition is unique because it has these characteristics. They also had an aversion to protein, even though they might have improved their socioeconomic status, got a good job, they still didn't like protein in their diet. So this condition is unique. It's not autoimmune, it's not genetic, it's not pancreatic. They do have insulin secretion, but 50% respond to oral antidiabetic agents. Hepatic glucose output not as elevated as type 2, not as low as type 1. And they have body fat percentages which are much lower than type 2 diabetes. Why does it happen? So we think it's due to various factors which have resulted in malnutrition, and the unfortunate thing which we are not obviously proud about is that we still do have stunting. Dr. Das had mentioned that we do have undernutrition in parts of our country, and we also have the highest prevalence of low birth weight. So a combination of antenatal malnutrition along with postnatal malnutrition, which may not be a major issue in a state like Kerala, but is true in rural parts of many other parts of the country, may be responsible for this condition. We have looked at low birth weight individuals at the age of 22, and we always have found that they tend to be shorter, lighter, reduced muscle mass, and have an increased diastolic blood pressure. So this thing about having low birth weight is a risk factor for subsequent development of diabetes and relatively people who are more lean. If you have malnutrition after birth, then they can develop something which is somewhere between type 1 and type 2. Very lean, may respond to OADs of 50%, but do not have ketoacidosis or other hormones. If you make these people exercise, what happens to them? They do improve their body composition. So the percentage body fat will come down and they improve their muscle mass. So they respond to exercise. It's not written on your forehead if you're born low birth weight that you're doomed to get diabetes. They respond to exercise. So some finding things that I know buzzer is buzzing, but C-peptides are very useful. Maybe you can photograph it, you won't do that, you have to talk about it. In the early differentiation, simpler, cheaper tests which you can do, and then think about the GAN antibodies. Yes, you should do imaging of the pancreas, and how DEXA scans can actually help in differentiating. This is more like a type 2. Look at the percentage body fat on the left-hand side. It's all kind of high, light, body log. It's not superficial weight, it's the opposite. The head actually is lower than the rest of the body, unlike lipodystrophy where the head has a higher percentage. So these are the DBs that you should think about. I think I've covered most of them. I haven't talked about HIV lipodystrophy. That's another story which we'll come to at some other point of time. But remember, genetics is important, environment is important, and both historical, nutritional, and social issues contribute towards diabetes. Our genetics team, the clinical team as well, my co-consultants, previously residents as well, and people who have worked with us and are working with us at this point of time. Thank you so much for your patient listening. I'd like to invite you for a meeting which we're having in the month of January on diabetes and various aspects. Today meeting on the 10th and 11th of January, and we have around 30 international speakers who are also attending this. Thank you so much for your patient listening. Thanks for the opportunity.
Thank you very much, Dr. Master.